Awesome. So
Okay.
I'm going to do then is, do you want me to go ahead and share my slides now, or how do you want to?
I'll go ahead and just introduce you real quick and kind of talk a little bit about the idea for this meeting. And so welcome everybody. I think a lot of you are associated with our Colorado Heart Healthy Solutions program. And for those who are not, welcome. And so today we're going to do a presentation of the 2022 Standards of Medical Care for Diabetes. Dr. Cecilia Low Wang, who's a clinician scientist at CPC Clinical Research and a professor of medicine at the University of Colorado School of Medicine, is going to lead the presentation, and then we'll have a subsequent discussion and questions. And then we're going to go over that and then also kind of just talk about a pilot study that we're doing in collaboration with Virta Health that we're pretty excited about. So with that, I'll hand it over to you, Cecilia.
Great, thanks. And I just wanted to mention that Ray Estacio is also on the line, so he'll be here too. He's a co-PI on this trial, so I wanted to make sure people knew that he is here and available for questions as well. So let me share my screen and get started. Can you see that okay?
Good.
So what I'm going to do is switch over to the presentation view. How's that? All right. So this is going to be selected highlights from the 2022 ADA Standards of Medical Care for Diabetes. Diabetes is kind of my life. I'm an endocrinologist, and I wear a lot of different hats, including medical education on campus, as well as clinical trials. And I take care of patients both in the clinic, as well as I run the inpatient glucose management team at the University of Colorado Hospital. And so I think about diabetes from lots of different angles and different perspectives, and encounter people with diabetes kind of every single day of my clinical work. So we picked out a few of the highlights from the 2022 standards, and I hope that you'll find this interesting. So hopefully the presentation will take maybe 30, 35 minutes, and then we'll leave lots of time for questions at the end. So the objectives today are really just to pull out some parts of the standards that are related to population health, improving health outcomes through behavior change, digital health technology, and because the newer medications are such an important part of the way we think about diabetes now. I also have several slides on how to select among the different agents. And then I wanted to go through the rationale and design of our current ongoing pilot trial for type 2 diabetes, Victor Pilot. So here is how the standards look. And so of course the ADA puts this out every January as a supplement to diabetes care. And what they've done is they've started releasing these in December the previous year. So here is the QR code if you'd like that to get to the full text version of the standards, but you can also find it online as a supplement to diabetes care. So there are a few updates that were made this year, and I really was excited about the fact that finally the ADA decided to bring up the concept of health literacy and numeracy as a really important topic in the care of diabetes. And so, cost is a big one, but then the other is health literacy and health numeracy. And I find myself talking a lot about cost with my patients with diabetes when we're talking about medications. And so that's a major source of health disparities. And so, just like with so many other things, we really need to be aware of costs, and then just have all the different tools for diabetes management in our toolboxes so that we can talk about this in the context of our patients' concerns, which often include cost. And the other part is that, it's kind of funny. I tell people that, I was going to be a pediatrician, but then I was turned off by the fact that there was a lot of math in pediatrics. So you're always having to calculate things by weight. Turns out that diabetes also needs a lot of numeracy in it. And so I didn't get away from having to do a lot of math when it comes to managing diabetes. So of course, health literacy and health numeracy, there are different levels among our different patients. And that can really, I think being aware of that is super important to be able to meet our patients where they are, and then make sure that we're talking with them in a way that they can understand and be able to implement different changes that we're hoping that they can do to manage and monitor their diabetes. So the definition of health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate decisions. And I have to say that having this basic health literacy is important, but then also knowing how to parse out misinformation is super important, especially in the era of the internet. Health numeracy requires primary numeric skills, applied health numeracy, and interpretive health numeracy. So there are different components to that. And there are some different numeric tasks that might be required for diabetes care. We're often focused on numbers, and being able to present that in a way that all of our patients can understand, I think is really important. And then the really cool thing is that in section 1, the community health workers content was expanded. So I'll tell you a bit more about that. So in terms of tailoring treatment for the social context, so I mentioned cost is one, but then also the importance of assessing food insecurity, housing insecurity, homelessness, financial barriers, and then trying to figure out what support there is to inform our treatment decisions, and then referral to appropriate local community resources. And again, they call out the importance of lay health coaches, navigators, and community health workers when available to help patients with self-management support. And so then they go into a lot of detail about what this actually means. And so they felt that community health workers, peer supporters, and lay leaders can help with delivering diabetes education, particularly in underserved communities. And so what a community health worker is defined as is a frontline public health worker who's a trusted member of and or has an unusually close understanding of the community served. So I think it's a resource that, I think wasn't as well recognized before, but there's enough really great research now to show that the role and the importance of a community health worker. And then I think lots of different organizations, including the ADA and the American Public Health Association, are really putting forth community health workers as being an important part of our way to manage diabetes on a population and individual level. And there's some great research to show this. And so just to go on about what the standards say about community health workers, they mention that the scope of practice includes things like outreach, communication, advocacy, social support, basic health education, as well as referrals to community clinics. And so those have been shown to be successful in providing social and primary preventive services to underserved populations in rural and hard to reach communities. And so then they go into a little bit more detail, but I just wanted to say that I'm super excited about all this detail about community health workers and the new standards, because of course the CPC Community Health program, Colorado Heart Healthy Solutions, the backbone of that really relies on community health workers. And so I think this is just really exciting. Moving on to the next section. So this is classification and diagnosis of diabetes. So again, I'm just pulling out some of the different highlights that I think are really important to know about. For one, it's that screening for diabetes should start at the age of 35. So that's one big point to remember. But then the other thing is to remember that point of care A1C assays haven't been prospectively studied for diagnosing diabetes. So for the diagnosis itself, we really need to validate either with a serum A1C or with other methods like a fasting glucose or an oral glucose tolerance test. So just a quick word about A1C assays and interference. There's been a lot done in the last several decades about trying to make sure that everyone's A1C testing is harmonized. So we're using kind of international standards for the A1C testing. And so here's another QR code with more information if you want that. But just a couple of points to point out are that the A1C can actually be artifactually higher or lower depending on the population you're looking at. And I think the best studied ones are listed here. So we know that African Americans can be heterozygous for a common hemoglobin variant. And so for any given level of mean glucose, it can lower the A1C by about 0.3%. So that can actually help, that can make us miss a diagnosis of prediabetes or diabetes. This is compared to those without this trait. And then there's another genetic variant carried by about 11% of African Americans that can also be associated with a decrease in A1C, but much greater, so 0.8% or 0.7%. And so that can really make us miss a diagnosis of diabetes if we're only relying on the A1C. So just remember that even though we use the A1C in so many ways, it's got its drawbacks. Section 3, which is about prevention or delay of type 2 and its comorbidities, just a couple of things. So there's an updated recommendation on metformin. And so there is just a bit of detail about who it's really recommended for. So especially for people who have a BMI of 35 or greater, who are between the ages of 25 and 59, people with a higher fasting glucose. So this is kind of a higher part of abnormal fasting glucose, and then higher A1Cs, so 6% or higher. So in that 5.7 to 6.4% range, it's that higher group that would have more benefit, or where metformin is recommended, not necessarily people who don't fall into those categories. And in women with prior GDM, and the reason for that is this latter population of women who've had prior GDM. It turns out from prior studies that their risk for diabetes is about 10% per year, 5 to 10% per year. So it's up to 50% or even 100% after 5 years. So women who have had prior GDM have a huge risk for developing diabetes. And so this is why metformin is recommended in these subpopulations of people with prediabetes. And then there's, some more information about weight loss and prevention of weight gain in the new standards as well. So moving to section 5, which includes diet, behavior change, and what they're calling facilitating behavior change and well-being to improve health outcomes. So they talk, just thinking about what's different about this year, in the carbohydrates subsection, there's been more emphasis placed on the quality of carbohydrates. So there's a fiber goal now. And so the new recommendation is nutrient dense carbohydrate sources high in fiber, so at least 14 grams per 1,000 calories, and then minimally processed. And so I think we're really moving towards trying to recommend complex carbohydrates. But what I wanted to point out is there are a few other points to point out that haven't changed about the goals of nutrition therapy for patients with diabetes. And so there's lots of different goals. With the healthful eating patterns. So trying to achieve and maintain body weight goals, goals with glycemia, blood pressure, and lipids, and then also trying to delay or prevent complications of diabetes. But then, of course, it's incredibly important to address individual needs. And so this is personal preferences, cultural preferences, the health literacy and numeracy, trying to read that nutrition label and do calculations on how many servings am I having, how do I multiply this, just there's basic health literacy and numeracy that's needed on this level as well, to address kind of food intake and kind of calories and carb content, et cetera. But then also access is important, access to healthful foods, willingness and ability to make these changes, and then what are the existing barriers to change. And I thought this was really important too, that we'd like to maintain the pleasure of eating by providing non-judgmental messages about food choices, while limiting these food choices only when we have great scientific evidence for it. And so I pulled out a few of the recommendations. So these are straight out of the standards. And so in this section 5, they reiterate that there's no ideal macronutrient pattern for people with diabetes. And so these meal plans should be individualized. There's a lot of different eating patterns that can be considered for the management of type 2 and to prevent diabetes in people with prediabetes. But they also have this last recommendation, which is that reducing the overall carb intake for individuals with diabetes has demonstrated the most evidence for improving glycemia. And you can apply this in a variety of different eating patterns that meet individual needs and preferences. So moving on to the next section on diabetes technology. So the ADA has been for many years used the term self-monitoring of blood glucose, or SMBGs. And so they finally replaced it with what we would rather use, which is BGM, so blood glucose monitoring. So they kind of changed that terminology throughout the entire thing. And then there are these things called smart pens. I don't know if anyone has heard of them here, but They've now changed smart pens over to the term connected insulin pens, but it's pretty cool. These connected insulin pens are basically where you can take fast-acting insulin, put it into these connected insulin pens. They need cartridges. And then basically the pen remembers how many units you took and at what time. Because a lot of the time with managing diabetes, you just can't remember. Like, did I take that dose? How much did I take? What time did I take it? It's hard to remember all that. So these pens actually will remember that for you. And these pens can also do the calculations for you if you have a carb ratio or a correction factor or something like that. So a little bit more about diabetes technology, because this is, one of the big areas that there's a lot of research and work going into this, is that, we think about continuous glucose monitoring for people with type 1 diabetes. Turns out that in people with type 2 who are not using insulin, routine glucose monitoring, including continuous glucose monitoring, is probably limited additional benefit. But for some people, it's actually been helpful to help them figure out the impact of diet, physical activity, and medication changes on their glucose. And, we often think of glucose monitoring to try to pick up low blood sugars. Of course, it's useful to pick up high blood sugars, to look at glucoses if someone's sick, and then also to see if there are discrepancies between the A1C we're getting and the glucose that you're actually measuring. And so I think there are some different reasons to use glucose monitoring and diabetes technology. And then one of the key things, this is a section in the diabetes technology standards, is that combining that technology with online coaching can be really beneficial in treating prediabetes and diabetes for some individuals. And so there's some online programs, but many of these include a health coach, but others actually help by remotely monitoring patient clinical data. So things like glucose levels, weight, blood pressure, and then also providing feedback and coaching. And so I feel like this is really important that the standards includes this information, that we have some data for this. And then moving on rapid fire to section 9. So this is the section about drugs, medications for glycemic treatment. This diagram is very, very busy, and they've kind of made some modifications since the last year to add some more detail. And I'll pull out some certain sections, but I wanted you to see the whole diagram all at once. And the main thing is that they really strongly recommend, and this is very evidence-based, that if individuals with type 2 diabetes have known atherosclerotic cardiovascular disease or are at high risk for that, or if they have heart failure, or if they have chronic kidney disease, then no matter what the baseline A1C is, or whether they're on metformin, or what their A1C target is, we should be thinking about medications that will lower their risk of atherosclerotic cardiovascular disease, worsening heart failure, and worsening kidney disease. So that's kind of what that left side shows. If they don't have any of those, then we have to think about some other different factors. And so I'll bring that up in a second. So this first part is I've already mentioned. So if someone has known ASCVD or indicators of high risk, and I have a slide that tells you kind of what they're thinking are high risk, then you would consider a GLP-1 receptor agonist that has evidence, or an SGLT2 inhibitor with proven benefit. If someone has heart failure, we clearly go to SGLT2s. And then for CKD, with or without albuminuria, we prefer SGLT2s. So that's kind of the bottom line. And really this other part in the upper right-hand corner of the chart is that it's important to reassess and modify the treatment regularly, so every 3 to 6 months. And so we should be rethinking this every single time we see the patient. And so here's a part kind of further down of the left side. And so there, kind of on top, I mentioned here that if you have CKD with or without albuminuria, you need to be thinking about an SGLT2 that has evidence. So that's actually most of them now. So canagliflozin or Invokana, but then also empagliflozin or Jardiance and dapagliflozin for SIGA, or some SGLT2s with evidence of reducing progression in the large cardiovascular outcome trials, or the GLP-1s. But the evidence is really the best for the SGLT2s for kidney disease. The heart failure data are the best for the SGLT2s. Just the hospitalization for heart failure is reduced significantly if you have underlying heart failure. But then if you have underlying atherosclerotic cardiovascular disease, we have evidence for both. And probably it's the best for CANA and EMPA under the SGLT2s, and then for these three for the GLP-1s. And then there's some more detailed, depending on what your GFR is and some other things. But definitely, if you can't get to your A1C goal, you should be intensifying the treatment. Here are the indicators of high risk. So one of the things that is often not so clear is, what does high risk mean? And so in the trials, the people who were considered high risk in the cardiovascular outcome trials were people who were the age of 55 or above with evidence of atherosclerotic cardiovascular disease. So coronary, carotid, or lower extremity artery stenosis, or left ventricular hypertrophy. So that was kind of the definition that was used in many of the cardiovascular outcome trials. And then just to show you kind of in this diagram of the pathophys of type 2, what are we talking about in terms of where these drugs are acting? And so with the GLP-1 receptor agonists, the medications are working in lots of different spots on the pathophys of type 2 diabetes. So it's working to increase the incretin action. It increases production of insulin, actually suppresses the production of glucagon, and because of that, suppresses hepatic glucose output, and then it also works on appetite. The SGLT2s work on the glucose reabsorption side of things, and so they work mainly in the kidney. And so I wanted to just have this slide here to show you the different GLP-1 receptor agonists that are out there. So I bolded the ones that have data for cardiovascular risk reduction. So it's Victoza or liraglutide, Trulicity or dulaglutide, and Ozempic or semaglutide. And these are the ones that are out there. Victoza was the earliest one, but it's a daily injection. And then there are 2 weekly injections. And then one point that I wanted to maybe 2 points I wanted to point out. One is that, I'll often go to trying to recommend more convenient medications and kind of simpler regimens for my patients. And so that's why I go with the weekly medications if I can. Of these two, we think of semaglutide or Ozempic as being pretty potent in terms of glucose lowering, weight loss, and Trulicity or dulaglutide as being, maybe a little bit less, except that now this has been approved for much higher doses. And so at these higher doses, you get more glucose lowering and you also get more weight loss. But the big drawback is that people can get some GI side effects from this. So you really have to start with low doses and up titrate. The SGLT2s, work at the level of the kidney, and they decrease glucose reabsorption by the kidney. And so people often lose about 400 or so calories through glucosuria when they are on SGLT2 inhibitors. And so how do you choose between those two? So this is another slide from some guideline that came out, a consensus statement that came out 3 years ago that I thought was really a nice diagram. So that's why I've included it here. So you kind of look at what's predominating and kind of what you're trying to really focus on, and that's kind of how you choose. So if it's ASCVD, you might choose a GLP-1 more so, although there's certain SGLT2s that also lower your risk. If it's more heart failure or CKD, then it's more the SGLT2s first. And then I have a few, this is kind of key information down here in the lower right, because it's often a little bit difficult to remember what the different GFR cutoffs are for these different drugs. So granted, I have to say one thing is that these are very expensive. And so if a patient's insurance is not covering this enough, or their out-of-pocket costs are high, or they're in a Medicare donut hole, then these are really expensive because the GLP-1s are over $1,000 a month out of pocket. And the SGLT2s are, between $600 and $800 a month out of pocket. So these are pretty much unaffordable unless they're covered in some way. And so even though they're really, really great and, high value drugs because they reduce the risk of macrovascular complications and all these other things, in some cases, if there's no coverage, people just can't afford them. And so I wanted to just bring that out first. But for our patients who have renal insufficiency, which CKD makes up such a high percentage of our patients with diabetes, especially as it progresses. For canagliflozin, the label basically says that you can use canagliflozin for GFRs of 30 or above, and you want to make sure you cut that dose down to 100 if someone's GFR is less than 60. So the doses are 100 and 300. For empagliflozin or Jardiance, that's okay for people with GFRs of 30 or above for glucose lowering. If you have heart failure, it's actually approved for 20 or above, but not below. So below that, you need to discontinue. For dapagliflozin, the label actually says that you can use it for GFRs of over 25. And so you won't get much glucose lowering less than 45 when your GFR is 45 or lower, but you will still get the benefit for reduction of heart failure and on kidney protection. And so you can use it for GFRs as low as 25. You can actually, if someone's already on it and their GFRs drop below 25, you can continue it, but you cannot use any of these if someone's on dialysis. So these are straight from the labels. So what about in patients who can't afford those agents or don't have underlying ASCVD or aren't considered high risk? What do you do with them? So the standards actually mention that you should strongly think about, of course, there's lifestyle, it's so important, but then think about a GLP-1 because it can help considerably with weight loss. But depending on what is the most important, so are you trying to minimize hypoglycemia, minimize weight gain, or promote weight loss, or you're considering cost and access, you might have some different pathways to go down. And so these are the agents that have low risk for hypoglycemia. And it turns out the thiazolidinediones, or TZDs, pioglitazone is generic now. So it can be more affordable than some of these other agents. And then you might consider a sulfonylurea or basal insulin. For weight loss, you're really thinking about GLP-1s or SGLT2s. You really don't get weight loss with DPP-4 inhibitors. And then for cost and access, really, we think about insulins, except that, whenever someone starts insulin, then you need to start glucose monitoring more. You're starting to pay for pen needles. I mean, there's so many things around that's besides insulin that needs to get paid for, that we also have to think about those costs. But sulfonylureas and thiazolidinediones are the cheapest out there besides metformin. And so as you can see, DPP-4 inhibitors are not here. They're not listed here. So they are expensive. They can lower your glucose, but they're not very potent, and they don't give you any cardiovascular risk reduction or any heart protection or any kidney protection. So we don't use DPP-4s in most patients just because the cost doesn't seem to give us the value. But I'll use it in selected patients, and I can, we can talk about that more if you have any questions about the DPP-4s. So there's one little pearl about basal insulin, and I found this in the standards, and I thought it was really important to pull out just because basal insulin is pretty commonly used to add on to therapy in type 2 after someone isn't at goal with their A1C. And we've already thought about, they're already on metformin, we're doing lifestyle, we've thought about the other agents, A1C is still not at goal, and maybe for whatever reason, they're on a GLP-1 and their A1C is still not at goal, or they can't afford a GLP-1. And so what is it about basal insulins that we have to be really careful about? So I think that those titrate to goal or treat to target trials were really great, where we have people up titrate their basal insulins based on their fasting glucose, except that the problem is that people can over basalize. And so people might have, if we're only focusing on fasting glucose to titrate those basal insulin doses, then people can be on huge basal doses that are more than what they really need. And so as soon as they get into a situation where they either are taking their medicines every single day, not missing doses, and if they need to skip a meal for whatever reason, then they'll get hypoglycemic. And so just some of the clinical signals where we need to look for these red flags are a basal dose that's pretty high, so more than 0.5 units per kilogram per day. A big difference between their bedtime glucose and their morning glucose is really important to look for. If they're telling us symptoms or showing signs of hypoglycemia unawareness, if they're having frequent hypoglycemia, or if they are not aware of their episodes of hypoglycemia, or if their glucoses are really going up and down quite a bit, so high glycemic variability. And so if we have these signs of overbasalization, then we should be thinking about reevaluating and further individualizing therapy. Usually that means cutting down the basal insulin dose and thinking about the rest of the day's glucose control. So moving on to section 10, and I think this is probably the last section that I'll talk about, is cardiovascular disease and risk management. And so just the reminder that it's multifaceted, so lots of pillars: glycemic management, blood pressure, lipids, and then thinking about agents with cardiovascular and kidney benefit. And at the bottom, just the foundation is lifestyle modification and diabetes education. That's the most important. And so here's all the information I was telling you about with people with established ASCVD or established kidney disease. We should be thinking about an SGLT2 or a GLP-1. And then people with established ASCVD or multiple risk factors, and I've listed them here, or if they have kidney disease, then we think about an SGLT2. And then if they have these things, then we kind of the difference among all these different recommendations are, depending on what agent you choose, you're reducing the risk of different things. And so GLP-1s will not give you a benefit for heart failure. It can give you some benefit for the kidney, but really for those two things, you should be thinking about an SGLT2. GLP-1s are great for potent glucose lowering, weight loss, and reduction of cardiovascular risk. And then one of the other things that's mentioned in section 10 is that the use of internet or mobile-based digital platforms to reinforce healthy behaviors may be considered a component of care. So this has been found to be really helpful for things like hypertension, and this was called out in the new standards. And then there's some new sections. And so there used to be a section that was called microvascular complications in foot care. They finally decided to separate those out. So now there's a section on chronic kidney disease and risk management, and then a separate section on retinopathy, neuropathy, and foot care. And so this to me is kind of a great summary diagram of thinking about the goals of care, and then kind of this cycle of thinking about how to take care of our patients with diabetes. And so looking at patient characteristics, thinking about the different factors, using shared decision-making, agreeing on the plan, implementing it, monitoring and supporting, and then reviewing, and then agreeing on further changes. And so I think this is really a great diagram that shows this. So lastly, I'd like to finish with telling you about Victor pilot. And so this is the ongoing trial that is in our patients with type 2. And here's the name of the trial. And here's the clinicaltrials.gov identifier that has a lot of the details about the inclusion-exclusion criteria. And this is where we registered our trial. So here's the trial itself in a nutshell. So it involves patients with type 2 living in 3 areas of rural Colorado that are served by Colorado Heart Healthy Solutions. And we're cluster randomizing to CHHS versus VERTA first. So that's kind of the cluster randomization. And so the 3 rural sites are Chaffee County, High Plains, and Northwest Colorado. And what happens is that people get cluster randomized to either starting with CHHS, staying in CHHS, or starting with VERTA. And subjects then undergo 3 or 6 months of the VERTA program, but then they end with 3 months of CHHS. And the primary outcome we're actually looking at in the middle, so at 3 months. So it's the change in A1C at 3 months. And the reason for this is that even though we've got other secondary outcomes looking at the rest of the trial, we really wanted some preliminary data to start thinking about a larger trial. And our secondary outcomes include things like weight change, med changes, are people reducing or increasing their use of medications, and then are their doses changing, and then some patient-reported outcomes, so some questionnaires. And we're looking for a sample size of 57, and we're probably about 3/4 of the way through. And so I really wanted to give a shout out to our community health workers. And Bev, you've done an amazing job with helping us with this trial. And I appreciate all the work of our health navigators. So here is the trial kind of here's our schema. And so we're starting out with adults with type 2 on medication, engaged in CHHS, getting cluster randomized to either starting with, continuing CHHS or starting Virta. And at 3 months, we look at the primary outcome, and then there's some secondary outcomes, including engagement in their care. And then this group moves on to switching over to Virta, while this group continues Virta for another 3 months. And then we have a 6-month time point where we relook at everything. And then the last 3 months, everyone goes off Virta, and then they are back in CHHS as the kind of the care that they're receiving without Virta. And then we relook at these endpoints at 9 months. And so what we're really hoping is to be able to finish this trial in the next several months and see, what ended up happening, because this will tell us a lot of information about dose of Virta, and then also Virta added on to a community health worker program that's established, and kind of how this is working in rural Colorado, what adjustments we need to make, and maybe some things that we need to focus on to help people get to their health goals. And so just some closing thoughts. So the 2022 standards includes lots of things. I mean, the whole thing is like almost 300 pages, 250, 300 pages. It's got some new concepts on health literacy and health numeracy. There's lots more detail about the role of community health workers in rural and underserved areas. It talks about the utility of a lower carb content as part of medical nutrition therapy to improve diabetes control. There's some information about digital technology, including the potential for remotely monitoring patient data and providing feedback and coaching, which seems to help. And then there's strong encouragement for evidence-based use of the newer agents, and then separating out diabetic kidney disease and some of the microvascular and foot complications. There's an abridged version for primary care that's available, and I forgot to include that in the slide here. I wanted to show you what it looked like, but it's in the Journal of Clinical Diabetes. And then I just wanted to remind you that this Victor pilot trial is ongoing. And what we're doing is we're doing a lot of the things that are in the standards. So we're incorporating an established community health worker program, the Colorado Heart Healthy Solutions, with the Virta program and digital health to try to understand how best to help individuals in rural Colorado achieve these diabetes-related health goals, and hopefully do all of this better. So I wanted to close with that. I feel like the sun sets and sunrises have been so beautiful lately. So here's a picture from my neighborhood. And I wanted to open things up for questions, but thanks so much for logging in today.
Great. Thank you so much, Cecilia. It's wonderful.
Okay. And I did want to mention that Brandon is here from Virta. So anyone who has questions about details about Virta and the health coaching and some of the processes and kind of what the program is, please don't hesitate to ask because Brandon is here.
Maybe I'll start off with the questions. Cecilia, that was a great presentation, a great summary of a very large volume of literature for the compliment. So the question I had was, at least for pharmacotherapy for diabetes, is there any role for DPP-4 inhibitors? I mean, they don't work as well, and then they're expensive, and I kind of like cross it out of my algorithm altogether, pretty much. Because if you're going to pay for an expensive drug, might as well get a GLP-4 because they can lose weight at the same time.
Yeah, absolutely. And I think the problem with the DPP-4s is that 2 of the 4 DPP-4s that are out there, well, there's some advantages to them. So one is that they're pills, so they're not injections. So if you'd like some glucose lowering, that's expensive, but potentially, if it's covered, then it's not as expensive. So if you want some glucose lowering, in a pill that doesn't cause hypoglycemia, then you might consider a DPP-4 inhibitor, but 2 out of the 4 actually increase your risk of heart failure. So that's one of the big cautions. And, they don't come along with any of the benefits to your heart or your kidney. And so I find that I tend to use them in people who can't tolerate anything else, or people maybe towards the end of life, where we're trying to give people something to lower their glucose, to keep it from being out of control. And we want it to be easy for them to take, and we don't want it to cause hypoglycemia. But they don't cause weight loss either. So it's really it's not. They've been around for a long time. The first one came out in 2006 or 2008 or something. But when all this information came out about SGLT2s and GLP-1s, they kind of started falling out of favor. So they're used in only a very select population of patients.
Thanks.
But I agree with you. I mean, they're pretty low on my list, but I think there's still use for them.
And there's no reason to combine DPP-4 inhibitors and GLP-1s because they're kind of similar.
No, I'm glad you brought that up. You would not combine those two because they work on the same pathway. And one of the other things, I guess, is that if you were trying to avoid insulin, for example, this is hard because they're so not very potent. The DPP-4s can be used in end-stage kidney disease with dose reductions. So, maybe an alternative to insulin.
Thank you.
Great. Are there any other questions for either Cecilia or for Brandon from Virta?
Or for Ray, or for you.
Or for Ray, right?
Yeah, to
Sorry,
ask
Ray.
about this CHHS program, or just I feel like it's a really great opportunity to answer any questions you guys have about any of those things, or diabetes in general. I feel like we've got lots of expertise here.
Any takers? No. Okay. Well, again, if you have any other questions, feel free to reach out later if you think of anything else. I will be sending, for those of you on, Holly and Bev and the folks from Northwest Colorado Health, the link to this video. And then also, I know we did an informational session on Virta, just to say what Virta is. If you want to send that to your providers also, that would be great. And I'll send that along as well. But thank you, everybody, for joining. Thank you, Cecilia, for presenting. That was wonderful. And have a good rest of your day, everybody.
Take care. Bye.
Bye-bye.